Will be the learning objectives of today's discussion: introduction of prostate, location, gross features, its relations, lobes and zones, then capsules of prostate, age changes, blood supply, nerve supply, and applied anatomy. Prostate is an accessory male reproductive gland, and it is fibromuscular glandular. Histologically, it is 1/4 fibrous, 1/4 muscular, and half of the prostate is glandular. And what is the function? The secretions of prostate, they add bulk to seminal fluid, and female homologue of prostate is paraurethral gland of skin. So that was the, what is the location? It is located in the lesser pelvis below the neck of urinary bladder, as we can see in the diagram, and on each side it is embraced by the pelvic diaphragm, that is the levator ani, and posteriorly we have rectum. In the posterior relation of prostate we have rectal ampulla, we can see in the diagram again. This is the sagittal section of pelvis. It is like an inverted cone. Its width is 4 cm, length is 3 cm, thickness is 2 cm, and it is among those organs where the width is more than the length, as we saw in case of cecum and pons. Its weight is about 8 grams. What are the parts? Because it is like a cone, so it has an apex and a base, and it has 4 surfaces: anterior, posterior, and 2 lateral. Now we will discuss the relations of prostate. Apex is directed downwards, and this apex is separated from the anal canal by the perineal body. It rests on the urogenital diaphragm, and base is directed upwards, and it is continuous with the neck of the bladder, and the junction of the neck and the base is marked by a groove which lodges the prostatic plexus, venous plexuses. Then this base is pierced by the urethra, as we can see in the right-sided frontal section of pelvis. Now coming to the surfaces, the anterior surface of prostate is narrow and convex, and it is separated from pubic symphysis by there is a potential space which is known as space of Retzius, where we have a retropubic fat. So anterior surface is narrow and convex. Coming to the relations of prostate, the posterior surface of prostate, it is broad and flat, and it is separated from rectum by facial septum, which is known as fascia of Denon Willis. This fascia of Denon Willis is very important clinically. Now, what is the origin of this fascia? Initially, what happens in fetal life, rectovesical pouch is deep, but later on the lower part is obliterated, and there we have the fascia. It is replaced by the fascia of Denon Willis, and it prevents the spread of prostatic carcinoma posteriorly. So prostatic carcinoma usually doesn't spread till the rectum. And posterior surface, it is triangular in shape, and it is pierced by the 2 ejaculatory ducts near its upper border. Now coming to the next surfaces, the inferolateral surfaces, which are related to the anterior fibers, and which are related to the anterior fibers of levator ani, and they enclose this the fibers enclose prostate gland in a sling, which is known as prostate levator prostati or pubourethral sling. You can see in this diagram how the levator ani is related with the lateral surface of prostate. So coming to the lobes. Now the concept of lobes has changed with time. Initially we had only 5 lobes of prostate. This was the surgical classification, and they are 1 anterior, 1 posterior, 1 median, and 2 lateral. So we can see in the diagram green colored structure lying anterior to prostatic urethra in diagram A is anterior lobe, and then yellow colored structure is the posterior lobe, and a small lobe which is very important clinically, is the median lobe between urethra and the ejaculatory duct and prostatic utricle. Brownish structure is the median lobe. Then there are two lateral lobes which are shown as purple colored structures in diagram C, and they are connected anteriorly with the help of anterior lobe, and posteriorly they are connected with the posterior lobe. So these are the lobes of prostate. But now the concept has changed. Now we only describe three lobes. This is the anatomical classification: one median and two lateral. Now in diagram A, which is the sagittal section of prostate, we can see that prostatic urethra, it is there between anterior lobe and the median lobe, and this prostatic urethra, it bears the opening of a blind sac, prostatic utricle, and also the ejaculatory ducts, and in between we have a median lobe, and then below the ejaculatory duct we have posterior lobes. So this is the present classification of prostate. And second diagram B, the diagram given below, number B, we can see the this is the coronal section, posterior half of the coronal section, and here we can see the urethral sphincter, internal urethral sphincter and external urethral sphincters, and also we can see urethral crest, which is nothing but the elevated structure in the posterior wall of prostatic urethra. This is urethral crest, and this urethral crest, on each side it bears the sinus, which is known as prostatic sinus, where we have the opening of prostatic utricle. And now we can also see on either side of prostatic utricle two openings, which are the openings of ejaculatory duct. So all these are the structures within the prostate. Then we have also this, there is a structure which is known as veromontanum or colliculus seminalis, which bears the opening of prostatic utricle. Coming to very important lobe, median lobe. It is a wedge-shaped structure, and it forms at the base forms uvula vesicae in the urinary bladder, and its apex is directed below. Now, as in the diagram given above, we can appreciate this median lobe, at how it is bounded in front by prostatic urethra and on each side by ejaculatory ducts and prostatic utricle. Why it is important clinically? Because it is the enlargement of this lobe only which produces benign hypertrophy of prostate and results in difficult maturation. In the diagram given below, we can see various features or various structures which are there in the prostate, like prostatic utricle opening. Then we have openings of ejaculatory duct, and there are numerous openings on either side of urethral crest, which are the openings of various glands, ducts of the glandular element of prostate. And this slit on either side of the elevated part urethral crest is known as prostatic sinus. Then there is a colliculus seminalis also, which bears the opening of prostatic utricle. Then we have two lateral lobes on each side of the urethra. On posterior aspect, these lobes are separated by a sulcus, which can be palpated by per-rectal examination, and lobes are connected anteriorly through anterior lobe, which passes anterior to the urethra. We have discussed it. So we can see the lateral lobe in these diagrams given on the right side. Now the concept has changed, and from the lobes now there are various divisions are the zonal divisions. Prostate has certain zones. We have three zones. 70% of prostate is the peripheral zone, and this peripheral zone is situated posteriorly, as we can see in the diagram, and it is cancer prone. Then central zone, 25% is central zone, which is located posterior to urethra. It is a safer zone. Then we have transitional zone, just 5%, which give rise to the benign hyperplasia of prostate. Coming to the capsules, there are two capsules, true and false. True is the condensation of the peripheral part of the gland itself, and false is derived from the visceral layer of pelvic fascia. Then there are ligaments also, medial and the lateral puboprostatic ligament, which join the prostate anteriorly with the pubic symphysis, and they are also the modification of the false capsule. Very important feature is there is a presence of venous plexus in between these two capsules, as we can see in these diagrams. And we have to remember that when we remove the prostate, the process is known as prostatectomy. Both the capsules, they are left behind, and it is called enucleation of gland, and it has to be compared with the thyroidectomy, in which the plane of cleavage passes between the false and the true capsule, because the venous plexus is lying below the true capsule. So these are the capsules of prostate, which are comparable to the capsules of thyroid gland. Now we have discussed these structures traversing the prostate: prostatic urethra, junction of anterior 1/3 and posterior 2/3, ejaculatory ducts we have already seen, and a blind sac, which is prostatic utricle. It extends upwards and backwards, and it opens at the elevated area, which is known as colliculus seminalis or veromontanum. So, coming to the supports of prostate, they are urogenital diaphragm, two pairs of puboprostatic ligaments, and posteriorly we have rectovesical fascia of Denonvillers, which we have discussed. So these are the supports of prostate. Coming to a very important part, that is the age changes. Histologically, if we see the slides of prostate, then it differs at various stages of life. If we take the slide, if at birth, then prostate is small in size and it is made up just of stroma and simple duct system. There are no follicles at this stage, and hyperplasia, it occurs in first few weeks. So negligible changes occur till 9 years of age. At puberty, it doubles in size due to the increased testosterone, and then there is increase in the follicles, growth of follicle it occurs, and stroma, it decreases in quantity. In adults till 30 years of age, glandular epithelium, it proliferates again, but after, and there is a more enfolding of glandular epithelium, and irregular lumen of follicle is there. After 30 years of age, involution starts and enfolding gradually disappears, and ultimately after 45 years of age, there is either atrophy or the hypertrophy of prostate, and myeloid bodies, they also increase in number. Blood supply, very important, by branches of inferior vesical artery, middle rectal, and internal pudendal artery. Venous drainage of prostate is very important because it is in the form of plexus, we have already seen, which was lying between two capsules, and it drains into the vesicle and the internal iliac veins. Now these are valvulus communications. The veins, they are forming plexus and they drain into the as you have already seen, into the bigger veins, and valvulus communication exists between the prostatic and the vertebral venous plexus. We know that there are vertebral venous plexus. They are complicated networks, and they follow along, they are just like longitudinal chains, and they are running parallel, and they anastomose with each other, where they anastomose with the vena cava, and superior vena cava and the inferior vena cava. So if there is any pathology or CA in prostate, then it can reach up to so higher levels till the vena cavas, and this vertebral venous plexus, which is known as the Batson's plexus, has three intercommunicating subdivisions. One is epidural, then there is a epidural which is lying outside the dura mater, then there is plexus within the vertebral body, and then we have external vertebral venous plexus, which is lying outside in front of the vertebral body, and they are connected with each other, and they are drained by the segmental veins also. So it is this Batson's plexus. What will it cause? It what happens that they are valveless communications. So if there is any carcinoma is there, then it can reach up to the skull, right, through this Batson's plexus. And not only Batson's plexus, and how it is reaching the skull, because this vertebral venous plexus, it drains into the intracranial dural venous sinuses. So there is involvement of vertebral column and brain. We can have secondaries in vertebral column and brain in case of CA prostate, and it is also communicating prostatic plexus with the internal iliac veins, through which it goes to the IVC. So metastasis of prostate can carcinoma prostate can go to heart also. Sympathetic supply, coming to the nerve supply, is provided by the superior hypogastric plexus. Parasympathetic supply is provided by the pelvic splanchnic nerve. Now coming to the applied anatomy, we have benign hypertrophy of prostate can be there, which usually occurs after 50 years of age. As you've already seen, this hypertrophy, it commonly involves the median lobe, right? And it what are the features? That more the patient strains, more retention of urine is there. So there is difficulty in micturition. It is a feature in BHP in case of BHP. On the diagram, we can see that how this prostate is palpated by per rectal examination. Finger is inserted in the rectum, and then we can appreciate the median lobe in case of hypertrophy. Then there can be prostatitis, which is inflammation of prostate, and carcinoma we have already seen, which usually involves the peripheral zone. And the most important diagnostic marker is PSA, prostate specific antigen. Metastasis can go to the vertebrae and pelvis, as we have already seen. So this comes to the end of the presentation. Thank you everyone for patient listening.